If you've ever even thought about fertility treatments, chances are you've heard the name Clomid. It's so often one of the very first steps people take. But here's the thing. How this drug actually works and who it really works for is a lot more interesting and way more complex than you might think. So let's break it all down.
So here's what we're going to cover in this explainer. First, we'll get into the super clever way Clomid actually tricks your brain. Then, we'll figure out who this drug is really for. We'll walk through what a typical 5-day treatment plan looks like. Then, we get to the big reality check, the massive gap between ovulating and actually getting pregnant. We'll dig into the downsides that don't get talked about enough. And finally, we'll figure out how you know when it's time to move on to something else.
All right, first up, the Clomid brain trick. You'd think a fertility drug would work directly on the ovaries, right? Makes sense. But Clomid's real magic, or its real trick, happens somewhere else entirely.
Okay, so its fancy science name is Clomiphene citrate, but pretty much everyone just calls it by the brand name Clomid, and its main job is to block estrogen receptors. But here's the key. It doesn't do this in your ovaries, it does it in your brain. And that one little action kicks off a pretty powerful chain reaction.
Check this out. It's like a hormonal domino effect. It all starts when Clomid goes up to your hypothalamus in your brain and blocks the estrogen receptors. Your brain takes a look and thinks, whoa, where'd all the estrogen go? We must be running low. In response, it sends out a rescue signal, a hormone called GnRH. That signal travels to the pituitary gland, which then pumps out two other crucial hormones, FSH, which tells the follicles in your ovaries to grow, and LH, which gets them ready for ovulation. See? It's only at the very end of this whole chain that the ovaries finally get the memo to get to work.
This quote just nails it. Clomid isn't a direct stimulant for the ovaries. Nope. It's a master of deception. It fools the brain into thinking there's a problem, and the brain's own natural system overcompensates and basically yells at the ovaries to kick it into high gear. Pretty clever, right?
Okay, so we know how it works, but the million-dollar question is, who is this for? I mean, it's a powerful tool for sure, but it is definitely not the right tool for everybody. So let's figure out if you might be that ideal patient.
Clomid really has a sweet spot. It's most effective for women who don't ovulate on a regular schedule, which is super common for those with PCS, polycystic ovary syndrome. It also tends to work a lot better in younger women who still have a good number of eggs, a good ovarian reserve. And sometimes it's used for couples with unexplained infertility, especially when you pair it with timed intercourse or IUI, that's intrauterine insemination, to just maximize the odds.
And this is so important to understand. Clomid is great at making you ovulate, but it can't do anything to change the quality of the egg that's being released. So if poor egg quality is the real problem, Clomid isn't going to fix that. Think of it this way. It gets more runners to the starting line, but it can't make them run any faster.
Okay, so let's say you and your doctor agree that Clomid is a good fit. What does a treatment cycle actually look like? Well, the good news is the protocol itself is really simple.
It's basically just a 5-day course of pills that you usually start on day 2 or 3 of your cycle. The typical starting dose is 50 milligrams a day. If that doesn't quite do the trick, your doctor might bump it up in the next cycle. And that last point on here, it's absolutely crucial. Ultrasound monitoring is so important, not just to see if follicles are growing, but to check on some other stuff that, well, we're about to get into.
And now we've arrived at the part of the Clomid story that is absolutely essential to understand. We know it's good at making you ovulate, but making an egg pop out and actually achieving a pregnancy are two very, very different things.
Just take a look at this. The numbers are pretty stark. Clomid is fantastic at its main job. It gets about 70 to 80% of women who take it to ovulate. That's a huge success. But then, look at the pregnancy rate per cycle. It just plummets, all the way down to about 10 to 15%. That is a massive gap between those two bars. Which of course leads us to the most important question of all. Why? What on earth is going on here? If ovulation is happening, why aren't the pregnancy rates way higher?
Well, the answer lies in the side effects. And I'm not just talking about minor annoyances. These are real physiological changes that can sometimes work directly against the ultimate goal of getting pregnant. These are the underplayed downsides of Clomid.
See, because Clomid works by being an anti-estrogen drug, it can have anti-estrogen effects elsewhere in your body. For instance, it can thin out your uterine lining, the very place an embryo needs to implant and get cozy. It can also dry up cervical mucus, which makes it a much tougher journey for sperm. For some people, it can even mess with hormone levels in a way that might not be great for egg quality.
And this is all on top of a risk of ovarian cysts and the more famous side effects like mood swings and hot flashes.
This slide just captures this central paradox perfectly. The exact same mechanism that helps you ovulate can create a huge unintended problem. That anti-estrogen effect that tricks your brain, it can also make your uterus a much less welcoming place for an embryo. You can have a perfect egg, but if the landing strip isn't ready for it, implantation is going to be really tough.
And of course, there's the one side effect everyone knows about, the chance of multiples. Because Clomid can often get more than one follicle to grow, the risk of having twins is about 5 to 8%. And this is exactly why that ultrasound monitoring we talked about is so important. It's to manage this risk and make sure not too many follicles are developing at once.
So, with all of this in mind, where does Clomid really fit into fertility care today? Let's talk about knowing when it's time to have a conversation with your doctor about moving on to other options.
For a while now, there's been another player in the game, an oral medication called letrozole. This little chart shows why a lot of doctors are switching to it. It tends to be gentler on the uterine lining, and it allows your body's estrogen to behave a little more naturally during the cycle. Because of this, many clinics now prefer letrozole, especially as the first thing they try for patients with PCOS.
And this is a critical takeaway. Clomid is a short-term plan. It is not something you should be on for a year. The data is crystal clear. If it's going to work for you, it's most likely going to work within the first 3 to 6 tries. After that, the success rates drop off a cliff, while those negative side effects can just keep building up. So when is it time to talk about a new plan? Well, here are some clear signals. If your uterine lining is consistently thin on those ultrasounds, that's a big one. Or if you're ovulating every single month but a pregnancy just isn't happening. For women over 38, time is just more of a factor. So spending too many cycles on a lower success treatment might not be the best strategy. And finally, if there are repeated early miscarriages, that could also be a sign that it's time to look at other approaches, like injectable medications or even IVF.
So here's the bottom line. Clomid can still be a really valuable, effective, and pretty inexpensive tool, but its value is only really unlocked when it's used the right way, for the right patient, for a limited number of cycles, and always with proper medical monitoring. And that leaves us with this final thought. In medicine and, in life, the simplest, oldest tool isn't always the right one for the job. Understanding all these little nuances of a treatment like Clomid empowers you to have a smarter, more informed conversation with your doctor about what's really best for your journey.